So we'll start on day 2 today, the last day again. We'll start off where we stopped yesterday. Today we'll start with Omphalocele Gastroschisis. These are the two most common, I think, not emergent, but urgent pediatric surgery cases that we get. They're both congenital disorders. The management in both is more or less the same, at least the anesthetic management. The one thing common that they have is both of them have herniation of abdominal contents. Omphalocele, the defect here is failure of gut migration from the yolk sac into the abdomen, whereas in gastroschisis, it's the occlusion of the omphalomesenteric artery. In omphalocele, the herniation is usually through the base of the umbilicus, and in gastroschisis, it's a lateral defect, usually to the right of the umbilicus. Gastroschisis has no sac covering the bowel that's exposed, so they lose heat. The chance of infection is higher in these kids. In omphalocele, the sac is intact unless it gets ruptured during birth. So the sepsis is low if the sac is not ruptured. And you can usually wait to treat an omphalocele in the operating room and correct it, whereas in gastroschisis, just because the bowel's exposed, the longer it's exposed, you lose heat, there's infection chances, sepsis, hence you take them once they're resuscitated into the operating room. Omphalocele is usually associated with other anomalies. About 20% of the time, it's cardiac anomalies. They can also have cleft lip, cleft palate, trisomy 13 or trisomy 18. They could be associated with Beckwith-Wiedemann syndrome, and if they have Beckwith-Wiedemann syndrome, these kids have a very large tongue, so intubation could become an issue with these kids. But on the good side with omphalocele is the bowel structure is normal, and if they don't have cardiac defects or any other defects, they usually do well. But if they have cardiac defects or other associated anomalies, the prognosis is not as good. Gastroschisis, associated anomalies are really rare. The downside is since the bowel's exposed, it's thickened, return of bowel function to normal takes a longer time, feeding problems could arise, and in the long run, they can have high incidence of adhesions, so coming back to the operating room for bowel obstruction because of adhesions is common. They could have stenosis or ischemia and perforation, malrotation, volvulus. Like I said, they both need good closures and early, but it's really not an emergency procedure. In gastroschisis, you need to take them more early into the operating room, but remember they need to be resuscitated first. In omphalocele, a workup is necessary first. They don't need resuscitation because the sac is there to cover the bowel, so they need to have an echo to rule out cardiac deformities and any other anomalies that this child could have. A main goal is protect the herniated sac, decrease heat and fluid loss if the bowel's exposed, decompress the stomach with an NG or an OG tube, and start prophylactic antibiotics. When you bring these patients to the operating room, make sure that the room is really hot. You don't want these kids to get hypothermic. You minimize the fluid loss and the heat loss by covering the sac maybe with a silo or a transparent sheet over the bowel. Continue to use the resuscitative fluids that the NICU started. These kids sometimes need over 100 cc's per kilo, so bear that in mind. They have already given 50 cc's per kilo and the child's still hypotensive. Well, the child needs more fluids just because it's lost a lot. A rapid sequence induction would be the good way to go with these kids. Evacuate the contents of the stomach first, just like a pyloric stenosis kit. Paralysis, especially if it's a small defect, you want to do everything you can to assist with primary closure of the defect. But if it's a large defect, they usually put a silo sac, tweak the belly down of the herniated contents down over a few days, and then bring the child back for secondary closure. During surgery, and you're contemplating a primary closure, you need to make sure that the peak inspiratory pressures at the time of primary closure do not exceed 30 centimeters of water. We don't measure intragastric pressures or CVP or bladder pressures, but if you do, you need to make sure that they are not really increased, just to make sure that the stomach's not pushed in with all these extra contents. When they do contemplate and do a primary closure, the downsides are ventilation could be compromised because of septal head pushing of the diaphragm into the thoracic cavity, and hence respiration's compromised. Aortocaval compression, there's decreased flow to the kidneys, the liver. You could also cause decreased blood flow to and perfusion to the gut, and hence perforation, necrotizing enterocolitis in the next few days. So you need to make sure that the intragastric pressures are not really high when they close. Complications for both gastroschisis and omphalocele include necrotizing enterocolitis, renal insufficiency. One could be because you have not resuscitated these kids, causing a pre-renal failure or problem. Second could be a primary closure resulting in raised intra-abdominal tension and decreased perfusion to the kidney. It could be abdominal wall breakdown, sepsis. In the long run, they could have reflux, aspiration from the reflux, pneumonias, and of course adhesions. And if they have other problems, they could have problems from the cardiac disease. One of the questions, I think, was the different types of hemoglobin or normal hemoglobin on your tests. A normal hemoglobin, which is hemoglobin A in adults, is made up of 2 alpha chains and 2 beta chains. It's 95 to 98% of our hemoglobin is hemoglobin A. Hemoglobin A2 is about 2 to 3%. It has 2 alpha chains and 2 delta protein chains. Hemoglobin F, on the other hand, it's about 2% of hemoglobin in the adults, has 2 alpha and 2 gamma proteins. Now, hemoglobin F, or the fetal hemoglobin, it's the primary hemoglobin that's present in the fetus during pregnancy. You don't need this. A question on your boards could be from physiologic anemia and why it happens. Just remember that the PaO2 in utero is really low, and because the PaO2 is low, the erythropoietin production is extremely high, and that's why the hemoglobin content in a fetus is extremely high. Following birth, the PaO2 goes up. When the PaO2 goes up so high, erythropoietin production goes down. With a decrease in erythropoietin production, new blood cells production goes down too, and that's why you'll see physiologic anemia around age 1 to 3 months of life. The crit usually doesn't go below 29, but if it does, then that child needs to be evaluated for some other problems. So, in a nutshell, once the physiologic anemia occurs, the child is still growing, and with increasing growth and metabolic needs, the oxygen tension goes down, erythropoietin production starts again, and then by the age of 5 to 6 months, the physiologic anemia starts getting corrected. I think thalassemia could be one of the questions in your boards. Like I said earlier, normal hemoglobin has 2 alpha and 2 beta globin proteins. Thalassemia, it's an inherited disorder. It could be alpha or beta. If it's combined with sickle cell, it could be hemoglobin S thalassemia. Thalassemia major it's really serious. These patients have profound anemia. They require multiple blood transfusions and growth retardation. They have a huge hepatosplenomegaly. They're prone for bacterial infections, of course, and can lead to chronic iron load just because of multiple blood transfusions. If they have thalassemia minor, they just have microcytic anemia. They don't need blood transfusions or anything like that. Bart's hemoglobin is when the child has 4 gamma chains instead of 2 alpha and 2 beta. Hydrops fetalis syndrome can occur when all 4 alpha chains are absent. Alpha and globin chains are absent in these kids. They club together and form what's called a clump of globin, I think, and causes decreased perfusion, decreased oxygen carrying capacity in these fetuses, and of course they die. Difficult airways in children. If you want to categorize them, you could categorize them into 3 categories. One is the hypoplastic mandible, the other one is midface anomalies, and of course the third one is macroglossia. In hypoplastic mandible, you have Pierre-Robins, Treacher-Collins, and Goldenars. They're not similar, but if you look at the Pierre-Robin syndrome kid, especially on the right side, there is no chin. There's absolutely no chin when you look at these kids. So they're micrognathic. Not only are they micrognathic, they also have glossoptosis. They could have cleft palates in about 50% of cases, associated with cardiac anomalies. Not high, but look for it when you have a child who has Pierre-Robin sequence. They could also have choanal atresia, so putting in a nasal trumpet to help them breathe is almost impossible. I mean, it's not possible. This question, I think, was there about 7 years ago, Pierre-Robin sequence and Stickler syndrome. It's myopia, blindness, and retinal detachment. How do you take care of children with Pierre-Robin syndrome? It's no longer called a syndrome, it's more a sequence of association. They present with airway obstruction, and because of the obstruction, they could be hypoxemic. They can develop cor pulmonale or congestive heart failure with severe chronic airway obstruction. They could have brainstem dysfunction because of central apnea and feeding difficulties. You know, they can't breathe and feed at the same time. They can do one of the two. So feeding difficulties become an issue in these kids. How would you manage them? They breathe well when the tongue falls out. So prone positioning is outstanding for these kids, or even a lateral position. And if that doesn't help, put a suture through the tongue and tie it or paste it to the side of the cheek, and that helps the tongue not falling back and they can breathe better. When you have to intubate them, I know it says pre-oxygenate in the prone position. Sometimes you need to use the prone position, but it's not always. Lateral position or any position where you can pull the tongue out, hold it, and pre-oxygenate these kids and go. The one thing good about the Pierre-Robin syndrome is LMAs work very well in these kids. And the way I intubate these kids is put in an LMA and intubate through the LMA. It's less stressful, it works beautifully, and it's neat. I don't do an awake intubation. Awake intubations are usually attempted when in the NICU when you do not have an anesthesiologist available. We do a sleep intubation, mask them in the prone position if you have to, and then put in an LMA and intubate through the LMA. Always be prepared for a trach in these kids. Make sure that you have a surgeon who knows how to do a trach in the small child when you take them to the operating room. The good thing about Pierre-Robin's children is as they grow older, the mandible grows. And so if it was a difficult intubation when they were born, 6-7 years later, it's really an easier intubation, much easier because the mandible's grown. That's no longer a problem. The Treacher-Collins syndrome, on the other hand, Just because you could intubate the child with the Treacher-Collins syndrome when they were 1 or 2 years of age does not mean you could do the same for 5 years down the lane. It gets difficult as they grow older. So don't be, don't say, I looked at his chart 4 years ago, he was easy, Dr. Reddy, you did it, and it's no problem, but it's 4 years ago, and today is a different story. So reevaluate these kids, always be prepared. In Treacher-Collins, of course, they have hypoplasia of both zygoma and the mandible. They're micrognathic. They have lateral pharyngeal narrowing, difficult intubation. Gets worse with age. Golden R syndrome is a hemifacial microsomia. They could present as difficult intubation too. One part of the face is normal, the other part is not. Mid-face hypoplasia is Apert syndrome. Hurler's syndrome, not only do they have a huge tongue, these children have cervical spine instability. That makes it difficult to intubate because you're considering inline stabilization in these children to intubate. I'll talk about Down syndrome a little later, but this is a picture of a child with Beckwith-Wiedemann syndrome. Just look at the size of the tongue and imagine how you would do a DL and intubate. LMAs work well. Pyloric stenosis. I think this is one of the most commonest semi-elective surgeries we do on young infants in our hospital. It's nothing but idiopathic hypertrophy of the circular fibers of the pylorus. Occurs within the first 6 weeks of age, more common in males, and that's why when you have a baby that's female, the diagnosis is not as straightforward. So when you take care of females in the operating room, these children have usually been dehydrated for a much longer period of time. You know, they think about infections, formula problems before they really say, oh, this is pyloric stenosis. So these kids need a little more TLC than the males. More common in Caucasians, lesser in the Asian population. They could be associated with cleft palate and GE reflux. They present with projectile vomiting. They could be hypovolemic. Along with that, they have hypokalemic, hypochloremic metabolic alkalosis, and that's because when they throw up, they lose the hydrochloric acid from the gut. And along with that, they could also lose some sodium and potassium. Metabolic acidosis can occur, especially when it's untreated. They get hypovolemic, perfusion's decreased, and these are children who are really sick. These children vomit, they lose gastric acid contents, the metabolic alkalosis, and the way to compensate would be to develop a respiratory acidosis. It's not a surgical emergency, it's definitely a medical emergency, and way to treat them is to rehydrate them. The fluid choice, normal saline. You start off with 20 cc's per kilo of normal saline. Do not use lactate in these lactated ringers in these patients to resuscitate. When you resuscitate them, you aim for sodium over 135, potassium definitely over 3 millimoles per liter. Make sure that the base deficit's good, well corrected. The CO2 is less than 30 and the chloride's over 100. One question on your boards was a child has moderate dehydration and gives you 4 different signs and symptoms, and you had to choose one of them. So I tried to get a good chart for that, and this is the best one I could find. When a child is moderately dehydrated, they lose about 5% of their body weight. When you look at them, they look normal. They may be a little more thirsty, maybe a little tachycardia, but not really so. So you really cannot distinguish them when they've lost just 5% of their body weight. But if you go to the moderate section, they lose about 10% of the body weight. Now these kids are irritable. They have dry mucous membranes. They could have, when you tent the skin, you know, it goes back a little slow. It could be a little tachycardic. The urine output could be normal or slightly reduced, but the main feature is irritability and a little tachycardia, a little slowed capillary refill, not really much. But if they're severe, you look at them, they're lethargic. You look at them, they look sick. And that's most important when you lay eyes. They do not pass your eyeball test. They're really tachycardic. They could have hypotension. They're parched mucous membranes. And you look at the sunken fontanelle. It's pretty deep and sunken. And prolonged tenting, eyes are really sunken. And that kid is probably metabolically acidotic too because of decreased perfusion. How do you treat? I think we went over this. If you don't treat metabolic alkalosis in these kids and take them to the operating room, the kids with pyloric stenosis, it's very hard to extubate them. You probably will leave them intubated. And if they have hypokalemia, you're risking arrhythmias in the operating room. And of course, they're so weak from post-operatively, you won't be able to extubate them. Management, after resuscitation, monitors, suction the stomach, do a rapid sequence induction after pre-oxygenation. We don't do awake intubations, we do asleep intubations unless there's some airway issues. And when you extubate them, make sure they're totally awake. Like I said, they could have respiratory depression secondary to CSF alkalosis. These are the kits that Dr. Brown loves to give caffeine. Almost every child who has pyloric stenosis, there's caffeine lying next to the patient to give at the end of surgery. I rarely use it, but you know, my thoughts are these children come in resuscitated, they do well. If they didn't have apnea bradycardia because of metabolic alkalosis on the floor, we shouldn't see that here. But with our general anesthetics, it's a possibility. And if they are truly apneic from metabolic alkalosis, go ahead and use a stimulant like caffeine. We went over that. Next question. Tetralogy of Fallot's. It's one of the commoner cardiac problems, cardiac anomalies we see in our patient groups here. Incidence is like 4 to 9% of the congenital heart disease. It has 4 components: a VSD, pulmonary stenosis, overriding of the aorta, and a right ventricular hypertrophy. A question on TET spells. They're usually episodes of paroxysmal hypoxia. The self-limiting lasts about 15 to 20 minutes, and they're characterized by cyanosis, tachycardia, and increased depth of respiration. Increased depth of respiration is to counteract the hypoxemic spell. Invariably, when you see a child who's running around and suddenly sits down, a child with a TET who's not been repaired sits down, it's because they know how to correct it. You know, they sit down, they squat, they increase the pulmonary systemic vascular resistance, thereby decreasing shunting. They get better because blood flow to the lungs improves, and then they run. And then after some time, they sit. So back home in India, when TETs were not corrected earlier, we would see this pretty common in the hospital. We're running around, and suddenly you see them sit, and then suddenly they're fine. The treatment is to improve pulmonary blood flow. How would you improve pulmonary blood flow? Decrease pulmonary vascular resistance, improve oxygenation in these kids, increase systemic vascular resistance, give phenylephrine. That really works well. Beta blockers, sodium bicarbonate, morphine have all been used to decrease the severity of cyanosis in the TET spell when it happens, especially in the operating room. The best treatment, of course, is surgical correction, and prognosis is really good in these kids. Question in your boards was how squatting treats a TET spell. Like I said earlier, they squat, they cause kinking of the major blood vessels in the lower extremities. That increases the systemic vascular resistance, thereby decreasing shunting from the right to the left, increases the pulmonary blood flow, increases oxygenation. So the American Heart Association changes these guidelines every 3 to 4 years. The current one states that for SB prophylaxis, the indications are one of the four subcategories. If a patient has a prosthetic valve or those that have a heart valve repaired with prosthetic material, you need to give SB prophylaxis for those patients. If they have a history of endocarditis, especially with that population, it's adults and children now, you need to give them SB prophylaxis. Heart transplant with abnormal heart valve function, give them SB prophylaxis. In cyanotic or congenital cardiac defects, these are the indications. A cyanotic congenital heart disease, you give them SB prophylaxis, especially in those where the repair has not been complete and they continue to have surgical shunts and conduits. A congenital heart defect that's been completely repaired but with prosthetic material, especially in the last 6 months, the time's not good enough for the whole prosthetic graft to be endothelialized, so that's why you have to give them SB prophylaxis. Last but not the least is a repaired congenital heart with residual defects, especially if they have persistent leaks or abnormal flow. Go ahead and give them SB prophylaxis. There were a few typos with the slide, I think, on your handout. So a meningocele is when the meninges herniates to a defect in the spine. A meningomyelocele is when not just the meninges but also part of the spinal cord herniates through the spine. The risks in these patients are infection and rupture. You have to be very careful when you position these kids, especially when you're going to intubate. Make sure that the sac is well protected if you're going to intubate them in the supine position. These kids are highly sensitive to latex, especially, I think it's because they're exposed to multiple surgeries in their lives, and they may also need a lot of catheterization for urinary retention. Hence, all children with meningocele, meningomyelocele, spina bifida, make sure that you don't expose them to latex. There was a question about 8 years ago with the association of Chiari malformation and meningomyelocele. Kids who have meningomyelocele have a higher incidence of type 2 Chiari malformation. I think it's Arnold-Chiari malformation. And these kids may need a VP shunt to decrease or to help with the obstructive hydrocephalus. TE fistula, we get about 3 to 5 a year. These kids have a high incidence of cardiac defects, 20 to 25%. They're preterm about 20 to 25% of the time and weigh less than 2 kilos about 25% of the time. If they're otherwise healthy and a good size, the mortality is almost zero. I mean, they do extremely well. High-risk patients are those that have cardiac defects, have a birth weight of less than 1.8 kilos, and have other problems like aspiration pneumonia, sepsis. In these patients, mortality goes up. The most common type is type C, where you have the proximal esophagus ending in a blind pouch and the distal esophagus communicating with the trachea. Diagnosis: when the mother's pregnant, all you would probably have would be polyhydramnios. Post-birth, when you see these kids, they have excessive salivation. They could have respiratory distress at birth or coughing cyanosis at first feed, especially when it's not diagnosed. And you try to pass an OG, you're not being able to. It just curls up in the posterior oropharynx and the blind pouch. When you do a chest x-ray in these kids, there is no gastric air bubble. There's absent intestinal air, and you could have aspiration pneumonia. TE fistulas are associated with multiple conditions. One of them is the Vactral association, where you have vertebral anomalies like a hemivertebrae or missing vertebrae. You could have anal atresia, duodenal atresia in these kids, cardiac defects 20% of the time, of course TE, presence of TE fistula, renal anomalies, which could include even renal agenesis. If they truly don't have kidneys, these children are not viable. Limb anomalies, they're usually absence of thumb or radial anomalies. That's more common in these kids. The other association is the charge association, where the C stands for coloboma, cardiac defects, coronal atresia, duodenal atresia, imperforate anus. They have both mental and physical retardation in these kids, cryptorchidism, and external ear abnormalities. Management: avoid feeding. When you see these kids are usually with their head at an angle or sitting up in bed a little bit, upright position. They have an OG with intermittent suction to suck out the saliva that they're not able to spit out. Antibiotic, prophylactic antibiotic treatment is initiated. Ensure that they have IVs in place to hydrate them and feed them, and they need ventilatory support if necessary. Management differs with each surgeon. Some surgeons, when we take the patient into the operating room, do a DL laryngoscopy, put a rigid bronch and see where the fistula is. And once you notice the presence of the fistula, you can think about how you want to place your endotracheal tube. Is it possible for you to place the tip of the endotracheal tube below the fistula? That's great if you can do that, but it's invariably not possible because the fistula sits just above the bifurcation of the trachea, and then you have to have the endotracheal tube above the fistula, and when you do that, every time you initiate back positive pressure ventilation, you'll be insufflating the stomach. And depending on how much you insufflate or how big the fistula is, you may have to have the child or the surgeon place a G tube in this child to decompress the stomach to help with ventilation and oxygenation. Just bear that in mind. When they do a DL, localize that fistula and plan and say, okay, I can place my endotracheal tube beneath the fistula, or I cannot place my endotracheal tube beneath the fistula, so I might have to have the surgeon do a G tube in these kids. Intraoperatively, I'm not sure if any one of you have been in the room with a child who has a TE fistula. Hypoxemia is the major concern. I mean, they compress the lungs. The surgeons do a thoracotomy. They compress the lungs. There's mediastinal retraction. There's tracheal pulling, tugging, deviation, cardiac compression, and all of this cause hypoxemia in the operating room. You need to have a surgeon who would coordinate with you and work as a team to help oxygenate and ventilate, and the surgeon do his surgery. The Mapleson circuits, or the systems, they're classified as A, B, C, D, E, and F, I think. And this classification is based on the location of fresh gas inflow and overflow valves with relation to the patient, wherever the Y piece of your circuit would be. A Mapleson D is most useful in children less than 10 years old. It decreases the work of breathing, and it decreases rebreathing, especially for controlled ventilation. If you have to use spontaneous ventilation, if the patient's breathing spontaneously and you have a Mapleson D circuit, you need extremely high fresh gas flows. But if you use a Mapleson A and the patient is breathing spontaneously, your fresh gas flow should be about 70% of minute ventilation, and that's all you need. But if you do controlled ventilation using a Mapleson A, you need extremely high fresh gas flows. So for controlled ventilation, a Mapleson D is a better choice. For spontaneous, it's Mapleson A, and that's where I think you'll have one of your questions. Now, a Bain circuit is nothing but a modified Mapleson D circuit. The advantages are it rewarms. You can rewarm, humidifies. It's pretty less. It doesn't weigh much, and you can have a good scavenging system attached to it. To prevent rebreathing, if they're breathing spontaneously, you need 200 to 300 cc's per kilo of fresh gas flows. If it's controlled, you need about 70 cc's per kilo. In children, the postoperative nausea, vomiting has about 4 factors. It's a little different from adults. The main ones being the type of surgery, eye muscle surgery, duration of surgery. If it's over 30 minutes, it becomes a risk factor. If the age of the child is over 3 years, it's a risk factor. And if there's a history of post-op nausea, vomiting, motion sickness, either with the patient or a sibling, the risk factor goes up by 1. How would you prevent it? Use drugs. There's been studies that have shown if you combine regional along with general anesthesia, the incidence goes down some. If you can do a subhypnotic infusion of propofol in these kids, it decreases the incidence of post-op nausea, vomiting. Give dexamethasone 150 mics per kilo. Of course, your ondansetron 100 mics per kilo. Your rescue drug would be droperidol, but we rarely use it because of its other side effects. Make sure the child is well hydrated. Use sativa if you can. If you have to use opioids, you use opioids. The other question you could have is post-tonsillectomy complications. I think one of the questions was the most common postoperative complication following a tonsillectomy is that pain, post-op nausea, vomiting, bleeding, and all of the above. We always forget the most common is pain. When you go see your patients in recovery, the first thing they say is, I hurt. And that is a complication. Make sure we undertreat rather than overtreat these patients, but make sure you treat them. So pain is a complication, and because of pain they don't drink, and when they don't drink they can get dehydrated. Mucous membranes dry up, and when they dry up, it's a vicious cycle. Pain increases, and now it's hard to catch up with that pain. So treat the pain. Make sure that you prophylactically give something for nausea, vomiting in the operating room for these kids. The other complication is, remember, I'm not sure if y'all do deep extubations or not, but if you do a deep extubation, it could be a wet airway, and if it's a wet airway, it predisposes to laryngospasm, and that could be a complication. Postoperative pulmonary edema from laryngospasm. You could also have postoperative pulmonary edema called the type 2 postoperative pulmonary edema. That happens because when these children come in for tonsillectomies and they have huge tonsils, these tonsils pre-surgically cause, because of the obstructive nature, cause some amount of PEEP in these kids. So they come to the operating room, you remove those tonsils, that PEEP effect is gone. And because the PEEP effect is gone, they can develop the type 2 pulmonary edema. You usually see it in the recovery room, about 30 to 45 minutes. You walk there and the kid's spitting up pinkish sputum, then you know it's a type 2 pulmonary edema, and you treat them appropriately. Bleeding is another complication. It could be primary or secondary. Primary is usually within the first 6 to 8 hours. Secondary is usually a week later. And the treatment for bleeding is make sure you resuscitate the patient, have blood available, suction the stomach out, have an extra pair of hands, and have 2 suction Yonkers available that's functioning could be difficult to intubate, especially when you see blood coming out. Have a surgeon ready to do a trach. Down syndrome, trisomy 21. They're the most lovable children. They're as sweet as can be. The issues, when you look at them, of course, it's easy to recognize. They have short neck, they have epicanthal folds, low set ears, and they have macroglossia. They could have mandibular hyperplasia, but it's not as much. Airway issues, not only because they have a larger tongue, they have atlanto-occipital dislocation issues. They have cardiac defects 40 to 50% of the time. The most common is AV endocushion problems. So AV canal anomalies, endocardial cushion defects, is the highest problem. They get bradycardic. You look at them, they get bradycardic. These are the kids that will probably, prior to induction of anesthesia, this is the one child that I would give atropine or glycopyrrolate. They could have pulmonary hypertension secondary to their cardiac problems. And because of airway obstruction from the huge tongue, they could have chronic hypoxemia. These kids have developmental delays, cervical spine disorders, thyroid disease. They're prone to leukemia. Just remember that that's one of your test questions. Could be obese, subglottic stenosis, and GI problems. Laryngospasm. How would you recognize them? Well, the definition is partial or complete closure of the vocal cords. How would you recognize them? There's inspiratory stridor. You look at these kids, nasal flaring, retractions, you know they're obstructed. And the most common cause of laryngospasm is irritating the vocal cords in stage 2. So when you extubate a child in stage 2, you know they're prone for a laryngospasm. A wet airway, you're prone. Tickling of the vocal cords, when surgeons put in lidocaine when they do their DL, that can cause laryngospasm. So as long as the child has an adequate depth of anesthesia, you won't see this, but if they're light, you will see it. Treatment is remove the cause. Positive pressure, hold it for a few minutes, gets better. If that doesn't work, if CPAP does not work, induce general anesthesia, give propofol. If that does not work, give succinylcholine. Complications are negative pressure pulmonary edema. But if you don't recognize it and treat it early, they can get hypoxic, brain damage, could be vegetable, could be death. So the few differences between adults and infants with spinal blocks. Remember, in infants and neonates, until about age 5 years, you do not see a sympathectomy when you do a subarachnoid block. It's only after that after age 5 that you would see a sympathectomy. And that's because the sympathetic part of the autonomic nervous system is not well developed in children. After age 5, it's almost normal. The termination of dural sac, S3 in infants and neonates, S1 in adults. The volume of CSF, it's 4 ml per kilo in children, 2 ml per kilo in adults. And that's why you need a higher dose in children when you do a subarachnoid block, because the volume of CSF is higher. The duration in neonates and infants, it's much lesser, just because the CSF turnover is so much quicker and faster. Your block won't last as long. And dural puncture, definitely less frequent in children than in post-puncture headaches, less frequent in children than in adults. Caudal block, it's a great block for children who have surgeries below the umbilicus. The technique is very simple. You palpate the sacral hiatus, feel for the sacrococcygeal ligament, give when you insert your needle at an angle, and then the dosage depends on what kind of surgery the child's having. Circumcision, you need about half cc per kilo. For inguinal hernias, then you probably need about 1 cc per kilo. The Drugs of choice are usually 1/8% bupivacaine or 0.2% ropivacaine. One of the common causes, especially when you do a caudal block in an infant that's less than 6 months of age, there's a possibility that you would inject your local anesthetic into the vertebral body. And when that happens, you can give rise, or into a venous plexus. You can cause local toxicity from the bupivacaine or ropivacaine that you've injected. These kids look for T-wave amplitude change. If there's over a 20% increase in the T-wave amplitude, think about local toxicity and treat it as such. The other complications for caudal block are dural puncture, rectal perforation, and that has happened. Intraosseous, again, injection and causing circulatory collapse, and treat it as local anesthetic toxicity. When you use a higher concentration in these kids, like 0.5% bupivacaine, and you send the children home and they're smaller, like toddlers, they could have urinary retention, and one of the common complications is a child coming back to the ER saying, this child has not had a urine output for the last 12 hours or 14 hours, and you look at them, they have a huge distended bladder, and that's a complication of your caudal block. If you think that the child has local anesthetic toxicity, and you call for help, don't hesitate, call for help. If you have an LMA, change your LMA to an endotracheal tube and secure the airway. If your child's seizing, go ahead and give Versed or any Valium for these kids. Start your PALS. You may have to initiate cardiopulmonary bypass, but with the advent of intralipids, give 1.5 ml per kilo bolus, and they usually do well with it. That's the end. Questions?